Welcome to the Senior Living 411 series. November is Fall Prevention Month, and for the entire month of November, we have been covering a multiple of topics. And just going to share the screen so you can see. And we've been covering a variety of topics related to fall prevention. And today is November the 26th, and I have Desiree King on the 411 on home health care. Caring for seniors and the elderly requires long-term planning and commitment. But many family members become caregivers overnight without even being ready for it. A loved one falls down or succumbs to some illness, and all of a sudden, their responsibilities change. After a certain period of time, the caregivers may realize they need more help. And so they'll go searching for different solutions for senior care, which may include home care. Senior care options like adult daycare centers or retirement facilities or nurses at home may not always be the right answer, and they may be more expensive. Home health care usually means a combination of non-medical and skilled medical or in-home nursing care services that enables seniors and others to live independently in their own homes for as long as possible. My name is Alpha King, and I am a senior home safety advisor in Ontario. I possess over 20 years of experience as an e-commerce solution analyst for a Fortune 50 company. My journey sort of into this world of healthcare started about 10 years ago when I was sitting in my mother's hospital room as she was awaiting a surgery for cancer. And all of a sudden, one side of her face went flat. When I called a nurse and they came in, they rushed her off to surgery. And I was told later that she was experiencing multiple seizures or mini seizures and mini strokes. And they had to put a stent in to stop this. Well, I was plunged into this world of senior home modifications for the next 4 years, and especially when my mother, who was 80 years old at the time, fell down to the basement floor. Well, luckily my wife, Desiree, or my fiance at the time, was experienced in this, and we were already researching some places to ease the stress for us. So I have since obtained my certification as a senior home safety specialist with Age Safe Canada, so that I can help others so that they can be ready for when something happens. So today, as I mentioned, I'm going to have Desiree King on, and she started her story a while ago, when she was at the age of 14. She, under the guidance of her mother, she volunteered as a candy striper at a local hospital. And her job was to deliver books to the geriatric ward. And in volunteering at this position, she realized two things: that she loved spending time with seniors and she enjoyed helping them. The volunteer position led her to work with seniors in a variety of other capacities. And in the past 30 years, she has obtained several industry licenses, including the Senior Home Safety Specialist, the Certified Aging in Place Specialist, Certified Senior Home Specialist, and the Gentle Persuasion Approach. She has also formed a network of industry professionals who communicate closely with aging adults and their families, and together they help them to modify their living arrangements, thus allowing them to maintain the best quality of life. Desiree has worked as a client care coordinator at one of the leading home health care companies in North America, and she was able to gain an in-depth knowledge and witness firsthand the realities that families face when they are plunged into this world of home health care. Desiree feels that working with seniors is not it's not just a transaction. It's a journey, and one that has led her to become a senior home safety advisor. Her vision remains steadfast to educate, equip, ensure, empower, and elevate seniors and their families through the age-in-place process as she arms them with top-notch information and access to other like-minded qualified professionals. I'd like to tell you, first of all, why fall prevention is so important. See, there's actually 4 reasons why we're doing fall prevention for this entire month. One is, the first one is that falls are common. Falls are the leading cause of fatal and non-fatal injuries for older Canadians. 1 in 4 older adults fall each year. And every 11 seconds, an older adult is treated in an emergency room for a fall. And every 19 minutes, an older adult dies from a fall. Number 2, falls can cause serious injury. Falls result in injuries such as hip fractures, broken bones, and head injuries. In fact, more than 2.8 million older adults are treated in an emergency department annually because of falls, resulting in over 800,000 hospitalizations. 3, falls are costly. The average hospital cost for a fall-related injury is over $30,000. Falls, with or without injury, carry a heavy burden on the quality of life. And after a fall, many older adults develop a fear of falling and, as a result, limit their activities and their social engagements. Fear of falling can result in further physical decline, depression, social isolation, and also feelings of helplessness. And the 4th reason is falls impact caregivers as well. Research has shown that after a caregiver recipient first falls, the caregiver reports a significant increase in their own burdens and their fear of falling and depression. Research has also shown that the toll on the family caregiver's health appears to increase over the time. So if you can prevent a fall, whether it is you as a caregiver or the person that you are caring for, you can save time, stress, and money. So today, I will now bring on Desiree King to talk about the 411 on home health care. Desiree, how are you today?
I am wonderful, Alpha. Thank you for that wonderful introduction.
Excellent, excellent. So tell me first, what's your story? Like, how did you get where you are today?
Okay, well, I know for the last 24 days, I've been repeating my story quite a bit, but this is sort of a pivot for everyone to hear about how I got into home health care.
Yes.
So basically, as you just said, I've been working with seniors in some capacity from the age of 14 up until now, and different businesses. And I was presented with the opportunity to care coordinator at a home care company. I went into this position basically with no directives. I was just given a desk, the software, and told this is what we do. So pretty much I navigated my way through it. And it's interesting that when you're in an environment that is really where you're meant to be, it came naturally to me. We would receive calls coming in from families who just had a parent who either have a parent that's being discharged from the hospital, or a parent who they're concerned with because they're not in town, or they're part of the sandwich generation, which is the generation that's caught in between usually themselves, their family, and their kids. So really, we know life is hectic, life is busy. We would get calls from families requesting, to know more about what the care involves, and how to navigate the system, so to speak. So like I said, it came natural to me. I received a lot of training with it, and its home care is something that definitely everyone should be aware of how it works, because it can be a relationship that is formed from the very beginning, from a parent who's lost a spouse, or someone who you're not there all the time. You can start the relationship from there when they really don't need the more not medical, but the more hands-on personal care side of it, straight through the relationship in the lifeline.
So for those of us who don't know what home health care, can you describe it? What is home health care to you?
So really, Alpha Home Health Care covers a wide range of services. There are services which are community care access, which is the government side of it. And then there's private home care, which should be used as an added benefit on top of that once you've maximized the care that the government is giving you. So it can range from, and this is on the personal care, companionship. On the private home care, it can range from companionship. On the government side, there is some personal care and even some nursing care, and that happens on both sides as well. In Ontario, the government side, it used to be called CCAC, which is Community Care Access Center, but now it's called LIN, which is the local integrated healthcare network. And there are several LINs throughout the province, different offices that offer the care.
Is this offered through OHIP, or can you use OHIP to get this type of service?
So with the government care, which is LIN, everyone who is covered by OHIP, which is the Ontario Health Insurance Program, is eligible for this. So when you locate your LIN office, and this is all divided upon based on the region you live in, when you locate, they will either come in or do a phone assessment with you to determine how much support the individual has. The more support an individual has, the less government care you will get, because it's really for people who are in dire need of this care. And usually they come in to do tasks such as bathing, grooming, changing, that type of thing. So that's where it stops in that arena. As for private healthcare, private home care, that is something that you would pay for out of pocket. It is not covered by OHIP. And again, that side of it offers things. Well, we can go more into detail on the services, but the government care, like I said, is covered by OHIP, and the private care is not.
Okay, so let's talk about the caregivers. How do
Sorry,
you?
just to interject, what I will say is sometimes, though, what I've heard the LIN is doing sometimes now is, if there is a case where there's care needed, they may even provide the funding directly to the family, and then the family can source out how to spend that in the private care realm as well. So that is an option. It's a circumstance I've heard coming up more often nowadays. So that is another option of it as well.
Okay. So as I was gonna say, let's talk about some of these caregivers. Like, how do you source them? How do you get these caregivers to
Yeah.
in your company?
So what I can speak on is the company that I worked with. I will not name the company just to remain neutral in this conversation, but pretty much we all follow the same type of protocol. Caregivers must have a vulnerable sector check done yearly. So every year, once it expires, the system usually flags us, and we do a vulnerable sector check. A vulnerable sector check, for those who don't know, is an enhanced criminal record check. So it's used to verify if an individual has a record suspension, which is formally called a pardon, for sexual offenses or anything like that, because we are dealing with the vulnerables check. And it also includes checks of the RCMP database and whatnot like that. We also ask for 2 to 3 employee references. Usually if we look for people that have experience in the home care industry, and especially because we work with seniors, we like people who have worked with seniors before. And we also, if the person's going to be doing transportation services for the client, then we also ask for a driver's abstract as well, along with their resume and proof of their immunizations, and proof of their college or university diploma or degrees.
Okay, so as if I was to get someone from your company, would I be able to get their references and information, or how does that work?
So if you're looking for references on the agency itself, because of privacy reasons, we cannot provide individual client information. If we're getting a contract, say with a facility, which is long-term care or retirement residence, we may provide them with references from other facilities to say how our caregivers work. As for the individual caregivers, one of the benefits that a family can have in knowing is that they don't have to worry themselves on background checks. As we do that, we vet them thoroughly, and that's also, for our insurance purposes as well. We have to ensure that we're vetting them purposefully. So that's one of the strains that are removed by using an agency, is that we take all that background work out of background work for you out of the picture.
Right. So what about the COVID situation with
Mm,
testing and things
yeah,
along that?
yeah.
What do you guys do for that?
So first of all, pre-COVID, caregivers would work in both in the community, which is going to private homes, and they could also work in long-term care or in retirement residences. With COVID, they have to, if they work in a retirement residence, and say retirement residence A or long-term care B, they have to only stay in that residence. They can't flip-flop between facilities or residences, as well as they can't flip-flop between community and residences as well. As you know, residences, there's several people in there, several caregivers, more people going in and out, which is why the transmission rate is higher, which is why we say if you're in one facility or retirement residence, you stay there. If you're in the community, you stay within the community. On top of that, again, the company that I worked for, they had implemented COVID assessment. We had a COVID assessment, which is an online form that's submitted each morning before the start of a shift. If any caregiver responds yes to any of the questions, we ask them to stay home. Any caregiver that were to have any form of symptoms of a cold, which is, as you know, mirrors COVID, we would then ask them to go in and get a COVID check. And as an added precaution as well for families, even though they've had the COVID test, we still want them to be clear from the first day of their symptom for 14 days before going back into the home of the senior. So yeah, and then the facilities now, they have in place as well. If a facility is what's a green or a yellow zone, I believe it is, they have to have a COVID test every 2 weeks. If they're in the red or orange zone, they have to be tested weekly going in, and they submit the results to us as well, and we keep it on file. So that's usually if they're doing what's called top-up care. So in facilities or residents, there's two things we can do. It's either staffing or top-up care. Staffing is just what it is, helping them with staffing when their own care staff calls in sick. Top-up care is when you have a family member in there and they need additional care over and above what these places are giving you. We come in and top it up for whatever reasons that you identify you need the person to come in.
Okay. So do you handle the training for these caregivers and
Yes.
for their different roles?
I wouldn't call it training, but the majority, so when a person applies as a PSW, for example, they usually have they do, not usually, they do have their PSW certification from a recognized institute. Also, students who are nursing students, after 1 year of schooling, they can also work as PSWs. And I will say that during the time of COVID, I found that a lot of the students we're really stepping it up. So I've got to give it credit to these younger people who came in as nursing students, and we're really stepping it up, especially going into the facilities when things were still so uncertain. They really did rise to the occasion and to their why as to why they were doing nursing. And obviously RPNs and RNs, which is registered practical nurses and registered nurses, they have to have their diploma degree and also be in good standing with the College of in Ontario, the College of Nurses. And each province has their own regulatory body, but I'm just speaking on Ontario where we are. And this is something that they renew yearly, every year by December 31st. So that's the type of credentials that they come in with. However, our agency, if we do decide to hire a caregiver, we have a general onboarding which teaches them about the culture of the home care company. Every home care company has a different culture, a different slogan, a different way of presenting their services. So we train them on the culture, as to what they can and can't do in their roles. And then there's also several online courses that we offer them as well for continuing their education. All of our caregivers are also usually trained in Alzheimer's dementia training, just because nowadays that seems to be a pandemic in its own right. We find that most people call in, it's either early onset, full blown aphasia, something related in that realm. So we try to make sure that all caregivers have that training, and facilities also require that as well, because it's a popular thing in there too.
All right. So, and that's ongoing training for them as well.
Yes.
So are the caregivers licensed? I heard you mention that they have their own license. And what about insurance?
So the insurance is covered through us, which is another benefit of using an agency. I shouldn't say us, I would say it's covered by the agency. Another thing I forgot to mention, just pivoting backwards a bit, is that all caregivers have to have updated first aid, CPR, AED training. AED is the automated external defibrillator. That's in case of a cardiac arrest. They're trained on how to do that as well. And that usually expires every 3 years. So we also monitor that they have that up to date. And we also do women's training, which is the workmen's health and insurance training as well. And yes, we cover the insurance for the caregiver, and they also have workmen's compensation and a whole slew of different liabilities. I can't even begin to go through them, but there's liability for theft, liability for this, liability for that. So they're fully covered for any and all things that can happen within the home.
So, okay, so now that you've done all your background check on it, how about us? Are we able to, sort of vet the caregivers? Can we meet them first before you just send somebody over?
Definitely. So when you first call an agency, usually they go through a brief overview on what services we offer. We try to identify what you offer, and then we offer a free assessment. Pre-COVID, it would be done in the home. With COVID, it's now usually done virtually. I'm speaking again from where I worked and seeing what a lot of the other places are doing. They do it virtually. And yes, there is after that's done and we decide we may want to work together, it's really, I like to call it caregiver matchmaking. So it's finding out not just the tasks that the family wants done. This is based on the person's ability, obviously. If it's someone who's bedridden, then it will be a task related assignment. But if it's somebody who's still pretty active, we try to find out their likes and dislikes, and we try to match it accordingly. Once we've identified that, during COVID, we do a caregiver introduction over Zoom or whatever conferencing. So there is an opportunity to meet the caregiver before deciding. And at that point, we just sit back and the family can ask whatever questions and the caregiver can ask whatever questions. And mom and dad are also invited to join in on the conference just to see who this person coming in is, so that when they come for their first shift, they're not surprised wondering, who is this person coming into my home?
Well, sometimes, that people's ways of being sort of just don't gel. And so, yeah, it might work on the phone or whatever, but then they get there and things don't work out. How easy is it to maneuver that situation? What do you guys do for that?
And that's another benefit of working with an agency, is that, yes, we have a inventory, so to speak, a whole roster of caregivers. So if it's not working, that's fine. It's nothing, not necessarily something's wrong with the caregiver or something's wrong with the person. It's just life. Sometimes personalities just don't mesh. So if that happens, instead of, if you're doing it yourself, you'd have to go through rehiring and the whole process again. It's no cost to us. We would just set you up with another caregiver. But we do try to have one person assigned to the household, a primary caregiver, because especially when you're dealing with someone with dementia, different people coming in and out of the home is not the ideal situation. Also, when you use more the government services, you don't know who's coming. It may be the same person sometimes, but it's whoever comes. With private home care, you have an option on who you want to come. And once we've identified a caregiver that's a good fit, what we usually like to do, again, this is speaking on the situation when I was doing the job, what we usually like to do then is introduce a second caregiver to shadow this person at the same time. So that way the person we're caring for sees this person, they meet this person, they're cross-trained by the primary caregiver. And if ever there's a sickness or vacation or whatever it may be, this person has already been introduced. So again, it's not somebody new just coming into the home, because you got to remember, it can be intimidating to have somebody just coming into your home, say to bathe you or maneuvering around your kitchen or whatever it may be. So we want to make it as smooth as possible that everyone involved is comfortable.
Okay. So how do I know? Okay, so now I've decided. Okay, I want this caregiver, and then we've come across, and mom needs 4 hours every day.
Mhm.
How do I know that the caregiver, like I don't live in the same city. How do I know that the caregiver, and what tabs do we have that we can watch and make sure that we are getting the services that we've asked for?
Okay. So a lot of families have cameras in the home. Simply put, they have cameras. They don't have to disclose that to us, but I know a lot of families have cameras in the home. Secondly, is with the particular agency I worked with, we have what's called a family care portal, which is a great, any agency you interview, I think they, we're in the 2020. They should have a system that you can log into. What our agency did was we formed what's called care notes. So what that would be is that the family, once we decide we're going to go ahead with this caregiver, we would give you some questions that you can possibly want to know at the end of each shift, and you can also add on questions. So for example, how is mom or dad today when the caregiver arrived? Is it a 1 or a 10? And remember, 1 or a 10 is, everyone's not always a 10. Some people are always at a 6. If that's what the person's normal is a 6, then it wouldn't be a flag. But if say they dropped to a 2, well, why were they at a 2? Is it a headache? Were they not feeling well? Did they fall possibly overnight? So how much did mom or dad eat? Did mom or dad take their medications? Does the family need to buy anything? Did anything happen today the family should be made aware of? Those are a sample of questions that would be in the care notes. And we encourage families to use this because wherever you are over the world, you can log in at the end of each shift and see exactly what happened on that shift with the caregiver. If it's something that's an emergency, obviously we will call you, but that is your point of knowledge. You can also well, in the system that we use, you can also communicate with the caregiver through this portal. You can even communicate with mom or dad if mom or dad is techno savvy, and your other siblings if you have siblings, through this system. So that's the best way. And also with our system that we used, if it was someone in private care in a home with a landline, as most seniors have, they would use that to log in and log out, and that's plugged into the system. So it's kind of like a geo tracking to know exactly where they are at that time. If they use their cell phone, again, it's GPS tracking, so we know that they're in that given location. And also, if they don't show up, I'm pretty sure we'll get a call from mom or dad saying, "Where's my caregiver?" or the family.
All right. So when I'm looking to pick someone, my mother has had diabetes, cancer. She's got pains in her shoulder. She's got a list, and I could go on and on.
Yeah.
How can we set up the right type of caregiver that has the experience for all these different chronic diseases and pains and different things? Is
Well,
that something that we can have as part of our lookup for
yeah.
the right caregiver?
Yeah, so as I said, we have all the agency I was with, I got to keep referring that, we try to have all our caregivers have dementia, some form of Alzheimer's dementia training, and that's ongoing each year as well. So that is like a baseline level of training. As for anything on top of that, like say Parkinson's or strokes, respiratory heart issues, if we need to have a specialized caregiver come in, if we don't have one on hand, then we will recruit one. We will go scouting for one for the family to ensure we have the right fit for the family. But generally speaking, we have caregivers that range from just graduated or nursing students straight up to 7, 8, 10 years experience. So if we're looking for something that's more intense like that, we would probably go with someone who has the more seniority and experience to bring in for the family.
Right. So I guess these would have different pricing for those kind of levels of care. Is there different levels of care? Like I know I have twin older my mother and my aunt, right? And they're twins, and one's very able, and one has a lot of pains and things like that. But even the one who's very able, she has her own unique. What if I just wanted, companionship? or something like that? Do you have that kind of service?
At the agency I worked at, yes, we did offer companionship services, which really to some people may seem like, okay, why would you pay someone for companionship? But when you have social isolation, as you noted, is one of the biggest things with seniors. So you may have, like I said, a mom or dad who's just alone. They don't have anyone really to speak to. You're not really in town, or you're not able to check in with them. What we would do on that type of assessment with you is identify, what does mom or dad like? Do they like knitting? Do they like sewing? There's a story I know from one caregiver. When they went on the assessment, they found out that, the husband had died years before, and mom had just completely shut down, showed no interest whatsoever in anything dealing with anyone, or not talking or anything. So we found out during the assessment, or the coordinator found out during the assessment, that mom used to like to knit. So we were able to pair her up with a caregiver who also liked to knit. In any event, the caregiver went over and they started knitting and whatnot. And one day the office got a call from the daughter saying, wow, what'd you guys do? Like, and we thought something was wrong. And they're like, no, my mom, I gave her a call and she barely had any time for me, because she was getting ready for the caregiver to come over. And they were going out to buy knitting supplies because there was this huge sale, and they'd contacted the church down the street, and they were making booties and blankets for babies. And they had an order prepared for next year. And she was putting on lipstick. I get chills when I talk about it, because the daughter was so happy that the mom received that spunk back. She was putting on lipstick, doing something she enjoyed. So the value of companionship is so important. And as I said, when you have a relationship that starts like this, there's a natural organic chemistry. If and when the health starts to deteriorate, you now have someone who mom or dad is familiar with, so there won't be as much resistance towards having this person in the home. And it's really a relationship that can start from there straight down the line as needed.
All right. All right. Well, now that we've kind of covered that area, well, how does the payment work? What are the costs like? Can you give me some kind of ideas here?
The average price for private in-home care, could speak about Mississauga, is around between, I would say, between $30 to, it goes up to $46 an hour for some agencies. So $30 to $46 an hour is the average pricing. Yeah, that's the average pricing. That's for a PSW. When you go into RPN or RNs, the prices go up. Now, usually with agencies, there could be a minimum of 2 hours, 3 hours, 4 hours baseline per visit. Some places have a minute number of visits per week, or some may charge a premium if it's just a once in a while usage for just say 4 hours this week, and probably next month another 4 hours. So it really depends on the agency that you contact. And if you need someone, like if someone needed say a RPN, because PSWs, for example, they don't clip nails, they don't administer injections or inhalers and stuff like that. So if you had someone that needed say diabetes injections and not able to, that person, they would only come in for about an hour, but it would be a higher price for the nurse or the RPN to come in to do that. So it really depends on the services and what's required.
Are there any hidden fees that I should be worried about?
Again, with the agency that I worked with, my format was, I'm not a hard seller. I don't do pushy sales. So my format would also always be to leave the exact contract that they would be signing not filled out with them to fully review. There are no hidden fees. So if you have someone that requires, say, errands or going to the doctor's appointments and stuff, then obviously there would be mileage. In our case, it was 75 cents per kilometer. If there was parking fees incurred, that's fine. Some families want the caregiver to go out and purchase items for the household. The caregiver would do that and then provide the receipt, and then it could be reimbursed on the invoice. Then it would be billed back to the family. So it really depends on the arrangement that you organize with the individual agency itself for payment for the fees.
All right. What about personal health plans? Do you cover those services?
So do you mean personal health insurance? Yeah. So, I've seen, it depends on the individual plan. I have seen families who come to me and say, mom and dad has a really generous plan. I'm not sure where they worked, but it covers both of them. And the insurance company may ask us for some documentation and stuff, and they're covered. Others don't. And it's sad enough to say, but private healthcare is really a luxury item, for lack of a better word. I also work with a nonprofit organization. I'm on the board, and what they do is something called the Buy Some Time program. And what we're doing is raising money that people can donate to this organization for people who can't afford private care, and Lynn won't really come in and give them as much care as they need. So this is a way we found to stand in the gap for seniors who are not able to do this by having the Buy Some Time program. And that way, if someone needs, say, 2 hours a week or 3 hours a week, it's paid for through the donations we've received, and we're still helping seniors because ultimately everyone deserves to have dignity and be treated with respect and have that care that they deserve.
All right. Do we have to pay up front, or could there be some kind of a payment plan for these services?
So again, I can speak on the agency that I was with. We would preferred method is a credit card on file. So basically, you can set up if you want it biweekly or monthly, and the credit card on file, you would get sent an invoice and we would bill it automatically. Sometimes there's a trustee on the account that would be billed to the trustee who's handling the funds, or some clients prefer to pay by check. And that's fine too. But for the majority, it would be by credit card. As far as a payment plan, my particular agency did not have one. And that's unfortunate, but no, there's no payment plan. There's just those options.
Okay, so we talked about the two types of what we talked about, the companion care and personal care. Is there any other different type of care that
Well, I
that you
don't think I
offer?
had a chance to really distinguish between the two, because that's one thing families should understand. So there's
Mm,
personal care fundamentally, and there's companionship care. Personal care includes bathing, grooming, if they need transferring, toileting, mobility assistance, feeding, that type of thing. Companionship care includes laundry, meal preparation, conversation, transportation, housekeeping, errands, maybe medication reminders, grooming. Again, with the medication reminder, most people have a blister pack. We are not allowed to, if it's in pill bottles, caregivers are not allowed to open the bottle and dispense medication. So it has to be in a blister pack, or if the family has those pill cases that have like Monday, Tuesday, Wednesday on it, the family is responsible for filling that. The caregiver cannot fill medications. They can only open containers, assist with popping the medication out the blister pack. They do not administer or open up medications or dispense it.
okay. So so once I've determined like what type of care I'm getting, do I have like an outline of what services are going to be given to the folks?
So with the agency I had, we have what's called a care plan. The care plan is a working document. The care plan starts from the minute we start having a conversation on the type of care that the family needs, and it's divided into different categories. So if there's housekeeping, well, Monday, Tuesday, Wednesday, Thursday, Friday, how often? Is it on an as needed basis? Is it every time that you go? We take note of what time does mom or dad wake up? What time is lunch? What time is dinner? What are their preferred meals? When do they like to have it? Do they want to be able to assist in making the meals? This is all a working document that's developed as the relationship strengthens, because a lot of times when you first go into the home, they don't think they need the help, and they don't realize how many things you can actually do until they start getting comfortable, and it's like, oh, okay, you know what, mom may have loved to cook, but she can no longer do this. Well, she can sit there and direct the caregiver on how to make her favorite recipe, and it becomes an interactive event now. So yeah, there's a care plan. This care plan is also shared on the family portal as well, so that the family can see what's in there and they can decide. Some families come with I've had people who've had very detailed descriptions on how to make porridge. It may seem small, but if that's how mom or dad likes their porridge, then we need to have the exact instructions. And this way, when another caregiver comes in, or the backup caregiver, they know exactly what's being done, how it's done. And it's also like a checklist for the caregiver to follow when they come in. They have this as a checklist to guide them along through the visit when they're there.
Right. So so this list also lists out who's responsible for what, and maybe is there like a list of what are their rights, what are the what's involved in this?
So in our agency, part of the documents that you receive, again, that I would leave with you would be, there is a client's rights and responsibilities. Like, for example, every client has a right to privacy. Every client has a right to being a part of the care plan. So sometimes the kids have one idea, mom or dad has another idea. I've seen a situation where mom she fell and injured her knee. Aside from that, when we went to visit her, the mother said to us straight up, listen, my knee is hurt, not my brain. Like she let us know that. But her kids didn't want her moving around too much. And she wanted to, when it was time for lunchtime, come over to the table and make her own sandwich. So the caregiver always has to, yes, we listen to the children, but it's also what mom and dad want. If she's able to do this and the caregiver can safely say, bring the bread from the fridge, put it on the table, get the jam or whatever, luncheon meat, and mom can make it, then that's what we're going to let them do, because ultimately we're not trying to take away their independence. We're just trying to enhance their capabilities and assist them in doing what they're doing. And again, this is based on the individual's person capabilities. So this is something that should be gauged accordingly.
So if we wanted something different, do we communicate with the caregiver or do we communicate with the agency?
We stress that, like, say, for example, you'd like the caregiver to leave early or come early or stay late. It has to go through the agency. That's for insurance purposes. Our insurance, we need to know when the caregiver is there because we're covered during that period of time. Similarly, if you say the caregiver is scheduled for a 4-hour shift, but after 2 hours you wanted to leave, you will still be billed. However, for insurance purposes, since we're responsible in that time, if the caregiver leaves early, we're not aware, we're not officially clocking off, something happens, that's a liability. So it's something that should be communicated through the office. It's a three-way relationship. It's the caregiver, the family, and the agency.
All right. Do we get the caregiver's direct contact information, or do we again work through the agency?
Again, in the agency I was with, we trained our caregivers that they shouldn't be sharing cell phone numbers and whatnot. It's an individual case, really. Sometimes you have the more independent families who, we had one family who every morning when the caregiver came at noon, they wanted their McDonald's coffee and a muffin. We don't really want to be called to be notified of that. So they can directly text the caregiver and say that to the caregiver. Do you get what I mean? So it really,
Mhm.
it's a gauged thing, but we do train the caregivers on maintaining professional boundaries. So professional boundaries are important because we tell the caregivers, although you will become like a family member, sometimes you're seeing this person more than their own children, you have to maintain that professional boundary. An example is there was a caregiver who the daughter was out of town all the time and she was the one primarily caring for the mother. The daughter came into town and something happened. I think there was a dispute between what was supposed to happen. And the caregiver said to the daughter, well, you wouldn't know, you're not here all the time. That's crossing a professional boundary. As true as it may be, that is not our right. This is still a client. So there is a professional boundary that we definitely stress has to be maintained. We stress to our caregivers, do not share your personal drama, for lack of a better word, with your clients. It's not something that needs to be shared. Gift sharing as well is huge. Do not take gifts from your clients. I'll share a couple of stories with you on that as well, just to give you some examples of why. Older people love to give gifts, especially around Christmas and whatnot, and that's fine. But we stress not to. If you're going to, let the agency know. This is our particular situation, how we dealt with it. There was a particular case of an older lady who had early onset dementia, and she insisted she had a beautiful Royal Doulton china set. For those who remember, who know what Royal Doulton is, that's very expensive china type stuff. And she kept insisting that the caregiver take one. The caregiver said, no, I can't. It's against the office rules. Eventually, she was becoming upset, so the caregiver took it, brought it right to the office. The office, realizing the value of this, called her son, who lived overseas in Europe, and said, your mom gave us this Royal Doulton, and he freaked out because this thing is worth over $10,000-$20,000. He came into town only to find that there was only half of this set remaining. Mom had a bunch of other people coming in, and they were taking it. So they weren't able to retrieve much of it, but it was still a red flag. Another example is if a caregiver accepts a gift, say from a family member, and the person has dementia, Alzheimer's, she gives it to them as a gift, but then forgets that she gave it to her and is now accusing the caregiver of taking it. How can a caregiver prove that they didn't take this and it was in fact given? It's going to be the client's word against theirs. So we're very stringent on gift accepting and like I said, maintaining professional boundaries.
So tell me something about the service times. I have some clients that get up early,
Mhm.
really early, And then I know of a client who might need some care around the clock, like maybe even a live-in. Do you do offer those types of services?
All of the above is yes. It's a 24-hour business. It's a 24-hour business. So it really depends on what time do you need. And then we find the caregiver who's able to accommodate that time. As far as live-in, yes, we provide that as well. That whole, I mean, do you want to go into the live-in right now? I can break it down for you because that's a whole different arena you're entering into. We can delve a little bit deeper into that. So when you look at live-in care, there's live-in care and there's 24-hour care. Okay, so that's when round the clock care is needed for the individual. So live-in care usually entails 1 to 2 caregivers. There's 24 hours in the day, and there's usually a sleep break for 8 hours. Usually a flat rate with a 4-hour break daily, which is paid. The pros of having live-in care is that the number of caregivers is reduced and there's consistency and relationships are built. So if you had around the clock live-in care for 24 hours, you might have a shift, say from Monday to Thursday, and then from Thursday to Sunday. That's how that would stagger between 2 caregivers in the home. Okay. Cons is that there's a 4-hour break during the day with no coverage, or you can have optional coverage, but there'll be an additional cost for someone to be there, or a family member can come in and take care of that mandatory 4-hour break they take. And also at night with a live-in, there's a mandatory sleep break of 8 hours, no coverage. When I say sleep break now, it's important to understand that if the caregiver is woken up, say a maximum of twice for the night, maybe to assist mom or dad with the bathroom care, that's still considered sleep. Anything that involves getting up more than twice would be considered awake. So there is a fine line between sleep and wake. And most families usually will start, we will see what happens over the first week. We will monitor how often the person's woken up before determining exactly what type of shift it would be. Now, 24-hour care requires a minimum of 2 caregivers, and they each work between 8 to 12 hours per caregiver, usually 12 hours. Sleeping break is optional depending on the family, and it's usually paid hourly if the caregiver remains awake, or a flat rate if the caregiver is asleep during the nighttime. The pros of that is the caregiver is there at all times. Awake at night caregivers are more refreshed and alert due to the rotation. The cons of that is that it's a higher cost, it's hourly billing, and generally live-in is half the cost and has less consistency in caregivers. So that's really the line between the two. But yes, we do offer that as well. And we've had clients who come in needing just 3 hours a night and say mom and dad, then dad suddenly has to go to the hospital. They don't want to leave mom alone because she may have dementia. We can then have the family can take care of dad in the hospital while mom now has the caregiver with her 24 hours, or vice versa. The person can go into the hospital and monitor and give that extra care as well, top up care with dad or mom, and sit there with them. So it really depends on it. There's no one fit for anybody. It's really customized solutions for your family's needs.
What do you do for emergency situations? Like you get a call and all of a sudden, something happened where, out of town, whatever it is. How do you help in those situations?
So in the initial assessment, we do ask questions as like the family doctor's name, who is the first, like we have a pecking order of who's the primary contact, secondary contact. We also have do not resuscitate orders. However, if there is an emergency, it's always 911. And the PSW doesn't have a right to really follow a do not resuscitate order. So we'd have 911 come in, and then they would be the ones to follow the procedures that would happen after that. And we also recommend, again, as with any senior living on their own, that they have a personal emergency response system in case the caregiver is not there, that they have this alarm on them as well.
If a problem arises with the caregiver, what's our course of action?
If there's a challenge with the caregiver, let the agency know. We do have disciplinary procedures that work from verbal, written to straight termination. Termination would be theft, fighting, smoking, even if the person smokes at the house, medicinal or non-medicinal, they're not allowed to join in. So it really depends on the level of what the caregiver has done and what the appropriate course of action will be and how many times the offense has occurred.
From our initial phone call to your agency, how long would it take before service can start? Like say it was Monday, I called in requesting, how long before I could get service? We'll say.
Depending on your specificities, so word if that's a word. But yeah, it really depends on how particular you are. We have some families who want someone who they're of German descent. They want a German speaking caregiver. That could be a bit more challenging. But if their primary concern is that they want someone who will care for their parents in the best way possible, that's highly skilled and qualified, we can have someone tomorrow. It's when it depends on how really granular this person wants to get for the family member.
Well, I think that most of my questions have been answered. You covered transportation to and from doctors. You've covered a lot of the information. Is there anything else you want to share with us about home
Yeah,
health
so
care?
a couple of things I would like to address because I do get this from a lot of people. So a lot of people say, well, you know what? Many of my friends hire ex nannies and pay them under the table, and why can't they do that? Well, it's illegal, number one. That's a good reason. You're breaching all kinds of tax laws, employment standards laws, workmen's comp laws, possibly even immigration laws. And another thing is you're not guaranteed service quality and guarantees. They're compromised. And there's significant difference in caring for children as opposed to elderly. Also, I've heard of people who have hired private caregivers and paying them under the table. They become unemployed. They go for unemployment insurance. You could be on the hook for $30,000, $40,000 or more if they do it. Even if they say they won't do it, you could be definitely on the hook for it. So that's really a bad idea. It's really a bad idea. Second is, people always ask why, well, they can hire someone themselves and hire and do all the necessary government deductions. Sure, go ahead. But it's a lot of administration. Same amount of paperwork for one person as for 30 people. So do you really want to be a mini payroll department is the question you have to ask yourself. And deductions are always changing. The laws are always changing. So you have to be always keeping yourself in the loop of what is going on and be prepared. Like you asked me earlier, what if we don't like this caregiver? Well, guess what? You've now got to place an ad, recruit, background check, interview, etc. So that's definitely, those are the questions we hear. We also hear about people wanting to sponsor people from overseas. That
Says,
is
yeah.
that is an option through the government live-in care program. There's a lot of paperwork, could take well over a year before someone arrives.
Hmm.
And again, you're responsible for all of the paperwork for their EI and all these different paperworks. And usually when you have someone come into that program, they want to get their landed immigration status. And once they get that, they leave. I personally went through that when I had nannies for my daughter when she was younger. So as soon as I think it's 3 years passes and they get their landed immigration status, they most likely do not want to be a caregiver anymore and they're going to move on to something else. So that's always a turnover that's happening. Outside of that, I'm just trying to think of what other questions I usually get. If the caregiver is injured, say if your parent requires lifting,
Hmm.
whether with Hoyer lift or just assistance with lifting, it'll be in the plan of care. We will provide a fully trained caregiver. And if an injury does occur, which is very rare, they are covered by workmen's comp and insurance. If you hire a caregiver on your own and they're injured, you can be liable for thousands of dollars of expenses. And the real fact is, most homeowner third party liability coverage does not pay out for improperly hired employees. So you can be putting yourself to save a buck, you could be spending a lot more should things go wrong.
Hmm. Well, Desiree, you have a wealth of knowledge in that head of yours. I'm so, there's so many questions that can come up, and it seems like you know them all. So I'm glad that you were able to help us get through this. Excellent presentation, as our panelists
Thank you.
have said. So keep up the great work.
Thank you.
Um,
Thank you. I really, I really want people to know that I, I, are we both talking?
Go ahead.
Sorry. I really want people to know that I really want people to know that definitely, the work that I do, it really comes down to it's caring. You're dealing with people's loved ones, and we have to come into it as though we're the children. Even how we address people, we train the caregivers. Some people, depending on their previous occupation, may want to be reserved that we be called by sir or doctor. So you really have to kind of follow the flow of how the family, for me, when I come into a home, if a family says, Desiree, this is mom and dad, then hi, mom and dad. That's how I'm going to, or this is Bob and Shirley. Hi, Bob. Hi, Shirley. This is Mrs. Brown. Hi, Mr. Mrs. Brown. So it's really understanding and mirror and matching how the family introduces you and how this person wants to be addressed. And, usually we also take note as well of the person's personality. Are they a peppy person? Are they more sedated? Are they active? Are they, so it's really, I like to, like I said, the best way I call it is caregiver matchmaking, but it's definitely something. We have a show coming up on the 29th, with a financial planner, talking on how to financial plan for the what ifs. And in this show, I actually went through numbers, live numbers on what it will cost if most people want to age in place, but they don't know the cost of aging in place, the true costs of the modifications, the home care, everything. So we're going to go through that, because if you have someone that needs round the clock care, you can easily spend 30 to 50 grand or more a year on care. So for me, I know as I age, I want to stay in my home. So now I've got a plan that if the what if happens, there's enough money for that. And people are living longer. People tell me they're 80. I'm like, you're still young. I know people who are 104. So it's all planning, and it's knowledge. You just got to educate yourself with the numbers, and don't just get tossed into this when it happens, because at that point your mind is spinning, different things are coming at you. You've got discharge planners. The person had a fall in the home, calling, you say out in the home. Discharge planner will not let them come back home if they require care in the home. They will not discharge them. The waiting list for long-term care is long, which is why fall prevention is the answer, because you don't want your parents ending up in any of those situations.
Wow, that is excellent. Let me open up and share these last couple of slides. Again, thank you so much, Desiree. You've, like I said, a wealth of knowledge there.
Thank you.
And, I can't begin to stress how much helping yourself or a spouse or an aging parent to avoid falls goes a long, long way towards preventing or preserving the health and independence. If you would like a link to any of this, to this presentation, or any of the videos that we've had over the past month, you can get that, and you can contact myself, Alpha, at seniorliving411.com, and or Desiree at seniorliving411.com, and we can provide that for you. Again, we have, slow to react, but physical activity benefits both your body and your brain. We encourage you to challenge yourself to move by taking note of why will you become active, and how you will build your weekly routine, and how you will keep your routine when life happens. Join Desiree King as she discusses the 411 on challenging yourself to move. Now that will be on Friday, November 27th. So look out for that. We'll see you tomorrow. Thank you again for joining us. Thank you, Desiree, for your presentation. And remember that all discussions can be also found on YouTube at Senior Living 411 Inc. And that's the channel on YouTube. We can also find us on our podcast at Senior Living 411 Podcast. And please remember to share this broadcast, share this information, subscribe and share the broadcast, and follow Senior Living 411 Inc. And also join us on our Facebook private page at the Senior Living 411 Series private Facebook group. Thank you again for joining us, and we'll see you again soon.